Welcome back to the STMCA podcast. This is Craig Thomas, MD3.
And I'm one of your other hosts, David Crump, MD2. And let me just say, Craig, I'm stoked. I've been waiting for this podcast for a while now.
Well, it is a podcast on everyone's favorite drug in emergency medicine. And David, I know it's especially one of your favorites, ketamine. So why
Yeah.
don't you kick us off?
So I tell all of my friends I joined EMS for two reasons, because I hate traffic lights and I love ketamine. Ketamine works as an NMDA antagonist, so it's fancy. You don't need to necessarily remember the receptor, but just know it's kind of a unique drug. And what it does is it blocks those NMDA receptors, or N-methyl D-aspartate receptors. And those receptors work on like downstream signaling for a ton of other receptors in the body. One of the most important receptors is actually opiate receptors. So if the NMDA receptor is stimulated, the opiate receptor doesn't work as well. So if we block the NMDA receptor, the opiate receptors lose that negative stimulation from NMDA, and the opiate receptors work better. So that's one of the ways that it actually works for pain control. It's nice because it's a pressure neutral pain medication. It doesn't drop your blood pressures like morphine or Dilaudid or some of those other stronger opiates can do, because it works in a different manner. Um, and so, I mean, there's a ton of other benefits to ketamine. I know we were talking about like the dissociation. I know you wanted to chat about that.
Yeah, but as you were talking about pain, just real quick, not only does it help in the acute pain setting, but also just longitudinally, it reduces the amount of opiates the patient needs over the next several hours, right? I mean, that's
Yes,
also a benefit of it.
100%. And I've had a great success in those. We've got chronic opiate users, people on Norco for long term, and this works amazing for them.
Yeah, definitely. So ketamine, always a good next line choice for pain control. And if you guys want to get a hold of us, that is definitely something we'll reach for.
Now, let's say you've got a patient in so much pain that you can't control it with your pain dose ketamine, and they are swinging agitated, Craig. What do you do?
Well, if somebody is to the point in time where we're worried about the safety of the patient and the safety of obviously you guys, the crew, then we're going to be using some chemical sedation to help that patient be calmer. And ketamine is one of the ones to reach to the quickest. So excited delirium is a situation a lot of times where an individual is so energized with all of their um, epinephrine and everything hormonally that's going on that we want to dissociate them so they don't go into a ventricular dysrhythmia. And so we use ketamine because it's quick acting. You can give it IM, and it is relatively long lasting. And so the dose typically is about 4 to 5 milligrams per kilogram for IM dosing, and that's typically what we'll do if we have an agitated patient. And we carry 500 milligram vials. So most times for your standard Michigan person, you're going to be getting a 500 milligram ketamine order. And if needed, now we have 2 vials on the rigs. So if we need to go above that or if we need to redose, it's something we're able to do.
And I would like to say, too, you might notice that we said 4 to 5 milligrams per kilogram here. And in one of the other podcasts talking about intubation, it's actually 2 to 4, but that's because you're not dealing with an agitated person. If you're trying to dissociate an aggressive patient, more ketamine will come on faster, and it'll more likely to overcome that adrenaline surge that comes with excited delirium. Ketamine also works great. We talked about putting a patient down. You can re-bolus it if you've got a long transfer that's intubated, or you're picking up an AUA patient from out in, say Tuscola, and you've got to transport all the way to Covenant or something. And so we had touched on that kind of, and I know you wanted to talk about why it's so useful in a lot of different kinds of intubation.
Yeah, as you said, you talked about the intubation dosing. That's really the go-to drug facilitated intubation medication that you want to use, particularly in asthmatics or your COPD patients, because it's a bronchodilator. It actually helps not only facilitate the intubation, but you're actually helping the pathophys underlying the disorder that is causing them to have difficulty breathing.
Now, I got an interesting question about intubation from one of the medics, actually, and I think it was one of the flight medics, but they had said, if I have a trauma patient that, say, got struck in the head, but I need to intubate, am I okay to use ketamine to intubate? Which I thought was a great question.
Yeah, there used to be a lot of thinking that ketamine would cause some intracranial hypertension, and so people were scared to use it in traumas, particularly closed head injuries. But it seems to be that that is no longer kind of the mainstream
Yeah.
thinking, and that it seems to be pretty safe.
Yeah, my understanding is that it very much it's a transient increase and doesn't clinically impact the patient at all. One of the things that you might notice too if you give ketamine, people will develop Rotary Nystagmus, which is something I don't think we talk about either. But it's a side effect that's known. Pupils will wig out.
Yeah, definitely. That's one of the things people notice the most, especially parents when we use it in the emergency department. But one of the main things, just along a lot of these induction agents, is apnea too. So as you're giving it for any of these indications that we just talked about at those higher doses, apnea is one of the things you really got to be looking out for. So making sure all these patients should be on a monitor. They should always have their pulse ox on them. And then obviously if they need some assistant ventilations, you should do that. You'll see it a lot of times with the higher dose and with how quickly the dose is given, you'll have an increased risk of apnea.
Absolutely. So as always, if you guys have any questions, feel free to reach out to us. I'm always happy to talk about why ketamine is one of my favorite drugs.
100%. I think that's all emergency medicine physicians. So if you have any questions, just get a hold of us and we'll see you on the next podcast.